All right, let's dive right in. We're facing a totally new reality in medicine, one where just treating a single disease at a time, well, it just doesn't cut it anymore. We're talking about multimorbidity, and today we're basically breaking down the essential playbook for navigating it. This is a whole new way of thinking that's all about treating the whole person, not just a collection of illnesses.
And this curve right here, it tells a really powerful story. You see, by age 65, more than half the population in wealthy countries has at least 2 chronic conditions. Okay, but watch this. By age 85, that number jumps to a staggering 80%. Now, these aren't just statistics, right? These are our patients, they're our family members, and each one has a complex story that the standard one-size-fits-all guidelines often completely miss.
So to make this all feel a bit more real, let's meet Mr. Chen. He's an 80-year-old man, and his story perfectly illustrates the challenges and, the solutions that we're about to unpack. He's going to be our guide for the rest of this explainer.
So first up, the patient's dilemma. See, Mr. Chen isn't just a list of diagnoses on a chart. He's a whole person with his own goals and his own fears. His situation is a really common but potentially dangerous clinical puzzle that we, as clinicians, have to solve. And not just by the book, but with real wisdom and care.
So here's a quick look at Mr. Chen's profile. He's 80, and he's juggling type 2 diabetes, chronic kidney disease, and some really painful osteoarthritis. He's on 12 different medications. I mean, that's a classic case of polypharmacy. He feels tired all the time, and he's at a super high risk for falling. But here's the thing that really, truly matters. His personal goal is just to stay active and live on his own. And right now, our treatment plan might actually be the very thing getting in his way.
So, how do we help Mr. Chen? Here's our roadmap for today. We're going to start with the problem, which is something we call the guideline trap. Then, we'll introduce a new patient-first way of thinking and a practical 6-step engine to put it into action. And finally, we'll talk about what it means to completely redefine the goal of medicine itself.
Okay, so at the absolute heart of this problem is the guideline trap. This is what happens when the very tools that are designed to help us, those single disease clinical guidelines, end up colliding with each other. And in the process, they can cause some serious harm.
I want you to think of it this way. For Mr. Chen, we have a blueprint for his diabetes, right? Then we have another one for his kidney disease, and a third for his osteoarthritis. Now, what do you think would happen if you gave those 3 separate, totally conflicting blueprints to 3 different architects and told them to build one house? You'd get chaos, a total mess. And in medicine, that mess can be really, really dangerous.
And this is what that chaos looks like in practice. As you can see here, to treat Mr. Chen's osteoarthritis pain, the guideline suggests an NSAID. Makes sense. Then, to protect his kidneys because of his diabetes, a different guideline recommends an ACE inhibitor. Also makes sense. But when you put those two together, that is a direct textbook recipe for acute kidney injury. We're following the rules, but the rules are working against each other, and the patient is literally caught in the crossfire.
So, how do we escape this trap? Well, we need a huge, fundamental shift in our thinking. This calls for a brand new framework, one that puts the patient, not their individual diseases, at the absolute center of every single decision we make. This quote right here is our new guiding principle. Align treatment decisions with individual goals, functional status, and life expectancy rather than isolated disease targets. So here's the bottom line. We stop asking, what does the diabetes guidelines say? And we start asking, what does Mr. Chen actually need to achieve his goals? It's a simple question, but it changes everything.
And this is the tool that makes that principle a reality. This 6-step clinical decision engine, this is our unified blueprint. It's a practical, repeatable process that guides us through all the complexity and makes sure our decisions are not only safe, but are truly centered around the patient.
Okay, so let's see this engine in action. We're going to walk through how to apply it step by step using our case study with Mr. Chen.
So here are the 6 steps. First, we identify all his issues. Second, and this one is so key, we assess his frailty. Third, we systematically review that super long medication list. Fourth, we decide on a plan with him. Fifth, we act, and that often means stopping medications. And finally, number 6, we review and we adjust as we go. Simple.
Now for step 2, we really need to understand Mr. Chen's overall health. Frailty is a much better predictor of outcomes than just age alone. A tool like the Clinical Frailty Scale, which you see here, gives us a quick, pretty reliable snapshot of his resilience. Understanding his frailty score is absolutely essential before we make any other decisions. All right, now for step 3, reviewing those medications. We don't just guess here. We use evidence-based tools like the stop-start criteria. This basically tells us when a drug's risk outweighs its benefit. For Mr. Chen, this is crystal clear. That NSAID for his arthritis, it's on the stop list for anyone with his level of kidney function. His eGFR score is below 50. It just has to go.
Step 4 is all about conversation. This isn't about us just telling Mr. Chen what to do. Nope. It's about using the shared decision-making model to explore options together. We talk about what matters most to him, his goal of staying active, and we co-create a plan that really honors that.
And that brings us to step 5, act. I want you to think of it like a balancing act, like this fulcrum. On one side, we're carefully taking away medications where the harm now outweighs any benefit, and on the other side, we're building up this non-drug foundation, things like physical therapy, diet changes, social support, all to improve his function and his quality of life. We take away harm, and we add real, tangible benefit.
You know, this whole thing brings us to our final and maybe most important point. All of these tools, all these frameworks, they're all in service of a much bigger idea, redefining what a good outcome even means for patients like Mr. Chen.
This time-to-benefit horizon shows us something absolutely crucial. See, a lot of preventative drugs, like statins, can take years to actually show a benefit in terms of living longer. So if a patient is frail, with a limited life expectancy, continuing that statin offers them little to no benefit, but it exposes them to the immediate harms of side effects. The whole risk-benefit math just completely flips on its head.
And this right here, this is the final shift. Our goal recalibrates. We move away from just chasing these isolated disease targets, like a specific blood sugar number, and we move towards what truly matters: comfort, function, and quality of life. It's about helping Mr. Chen live as well as he possibly can, for as long as he can.
So what are the key takeaways from this whole study guide? Number 1, think patient, not disease. 2, assess frailty to really understand their prognosis. 3, use evidence-based tools like stop/start. 4, master the absolutely crucial art of deprescribing. And finally, number 5, always align care with your patient's goals through shared decision-making.
And we'll leave you with this final thought. As you move forward in your clinical practice, just ask yourself this: is our greatest responsibility not just to add years to a patient's life, but to add life to their years? That is the real challenge and the true privilege of practicing medicine in this new age of multimorbidity.